My name is Kate Mbaire. I'm a senior M&E associate with the Measure Evaluation Program in Kenya. So the toolkit, it was developed to monitor the referral system in Kenya. Basically, we know in Kenya that referrals are happening. The referral system is there, but the monitoring of the referral system is what is the toolkit was supposed to bring out. Is anyone out there monitoring the referral system? And if anyone out there is doing that, how are the tools for referrals, the data collection tools for referrals? Are there indicators to measure referrals monitoring? So the toolkit is basically a document that has generic tools to monitor referral system. And those generic tools were applied during the period of the study in Kenya in 2 districts. So we implemented the toolkit in 2 districts in Kenya, in one region called Central. And the pilot covered 2 districts and 10 community units and their link facilities. What happens in Kenya is that a community unit is composed of community healthcare workers who are supposed to, they're level 1, they're at the basic level and are supposed to give public messages to the community, refer people from the community to the facility. So those community units, we chose 5 community units per district. I said 2 districts and 5 community units per district with their link facilities. By link facility, I mean a community unit in Kenya reports through a facility. If they have any documentation, any referral, they refer to that particular facility. So that's where we implemented the toolkit. This work was conducted, actually the pilot ended sometime this year in August. So it took a while. We selected the districts of work through the government of Kenya. We went to the community units and the link facilities, selected key persons who are going to implement the work, trained them, and they started collecting data. So data were collected for 6 months. From 2011, the year 2011, August, up to January 2012. Yeah. Okay. Yeah. So we had data coming from the facilities between those, for that period of time. Yeah. Mm-hmm. And then after you collected the data, what was the next? After we collected the data, of course, we were in constant support supervision with the facilities, looking at how they're filling in actually it's a summary tool. So basically what we did is, we didn't want to overburden the healthcare worker with more tools. So they used the original data collection tools from the government of Kenya and used the generic tools from the ARMAS toolkit to summarize referrals data. So we used to go down for support supervision to see how they're doing, if there is any clarification that's needed. And we also performed a data quality audit during the period of the study and looked at what are the issues that are coming out from the study. So we also held a one-on-one conversation with the point persons at the facility to ask them how the experience is the collection of data too much for them? Just talk to them about the experience of collecting data, yeah, for referrals. Mm-hmm. And so then how long was that process after the data was collected? After the data was collected, the process took about 2 months, yeah. 2 months process of discussions with the healthcare workers, going back to the facilities and giving them, and talking about what they collected. Yes, it took about 2 months, yeah. Okay. Yeah. And so then you mentioned your work with the healthcare workers on that. What was your specific role then? My specific role was to look at the data that the healthcare workers are collecting, then look at the issues that are coming up. The issues that are coming up, is the data quality? Is there some indicators that they're finding hard to understand, and kind of address that with the healthcare workers? Yeah. So it was largely quality issues. I would look at the forms in the office with my colleagues and figure out and look at where there were specific quality issues, then get back to the healthcare workers on that. Yeah.
And so when you say quality issues, what do you mean by that?
Quality issues, for example, in a facility they can report, I saw 15 people, but referred 25 people. Of course, you can't refer more people than you saw. So that's obviously an issue of understanding the indicator. Yeah. So that's a classic example of a data quality issue. Yeah.
Okay.
Yeah.
And so had you ever worked with anything similar to this?
With referrals?
Mm-hmm.
No, referrals is very new. In fact, I think somebody told me we might be the only country which is now scaling up referrals monitoring. So even to the healthcare workers, it was very new. They've been referring people as a day-to-day. I mean, as a healthcare worker, I see you, for example, then I refer you to the district hospital or to the referral hospital. But actually monitoring that process is quite new in Kenya. So it was a plus for us because the healthcare workers were telling us it's good. You're putting referrals monitoring on the map. You know, we've never really thought about referrals monitoring. The results that have come out have really informed the next steps. USAID in Kenya, we are expecting an associate award that's been funded through the USAID mechanism. And part of the work, the huge bulk of the work is referrals monitoring. So it's a good thing that we had this pilot because it informed, I mean, USAID was interested in referrals monitoring and decided to fund us, to give us more money to implement referrals monitoring. Plus, it's brought out so many gaps in the referrals monitoring from the data collection tools. The data collection tools are not adequate to capture referrals monitoring data. People are not trained in referrals monitoring. There's no specific protocol for referrals monitoring. So there's a lot of interest in referrals monitoring, but the system for monitoring referrals is weak. So I guess that's a challenge for us and a good thing with the award to embark on this. I had a chat with a USAID technical person for Kenya, and she came up to the poster and said, "Oh, this is great. You mean referrals actually do happen?" I said, "Yes, they actually do happen." Then she said, "Oh, you know, we visit facilities and and the healthcare workers tell us, you know, we referred this person, but we're never really sure that referrals are happening." So she said it's a good thing we have data, at least from the pilot study, to confirm that referrals actually happen. So yeah, I had interesting discussions with people who are interested in implementing referrals in their country. For example, there was a program officer from Uganda who wants to adapt the toolkit. Like I said, the toolkit is generic. It can be adapted to different countries. So he was very interested with the results, and he said he wants to take it up and implement it in Uganda.
So for them to do that, would you need to share, how could that process work for someone to sort of copy or scale up the toolkit in their context?
Yes.
Using what you did?
Well, what the first step would be for us to upload the finalized. For now, we are working on the toolkit and finalizing it with the changes that were brought on from the pilot. Then post it on the website, on the Measure Evaluation website, and kind of get reactions from everyone, and anyone who needs technical support on it, then we can give that to them.
I have a question if it's okay to get back to the health workers.
Yes.
So how did they respond, or how is it working with the health workers in the system?
For the toolkit?
Yeah, or did you find it important to use them?
Yes, they found it very important, but the main thing that was coming out from the healthcare workers was the data collection burden. I wanted to imagine, the healthcare worker in Kenya is really, I mean, imagine one nurse in a facility, and she has to see the patients, then she has to fill out all these forms. So the thing that came out from the study was collection for the data it was not easy for them to summarize the data, because the toolkit was a summary tool. So we required them to summarize data from different data collection points. So they clearly told me that data collection, data summary was a lot for us. But all in all, it made them realize the importance of discussing referrals data, and they saw the the benefits of discussing referrals data, they can actually advocate for more resources within the facility for referrals. For example, if a facility is referring maternity cases, a district hospital is supposed to provide maternity theatre emergency cases. So if this district hospital is referring all emergencies to another facility, then there's something that the facility obviously is missing. So with referrals data, they can actually have evidence that, look, I need an upgrade of my maternity, and this is my evidence. We've been referring X persons to this district hospital. So that in itself was very important for them, the use of the referrals data.
And so you mentioned the challenge of them being overburdened with the process of documenting everything.
Mm-hmm.
Were there other challenges in the program?
Yes. Yes, they had challenges in understanding of the indicators. The recommendations were, if we are to scale up, and these recommendations, we are taking them seriously, if we are to scale up referrals monitoring, we should word the indicators the way they are worded in the national reporting tools, so that it's not very different from what they're already used to. Because the pilot study worded some indicators different to what they're used to. So that would be one way of making it easier for them to word them just the way they are worded in the national. And then have more supportive supervision for them, probably monthly supportive supervision to check how they're doing. The other recommendation that we got was to shorten the toolkit. The toolkit was too bulky, so they need something that's easy to go over, not very big. Those are some of the key recommendations that we got. And training and retraining and having continuous sensitization on why they are doing, what's the importance of using referrals data, what do the indicators mean, how do they impact on them at the facility level or at the district management level. Yeah.
And so your team that was piloting the toolkit too, were there any challenges you faced for other people? The people who were implementing and piloting it?
Yes, there were some challenges. I think there were time challenges. I personally didn't go out as often as I would have wanted for support supervision. So that was the main challenge. Yeah. Yeah, I would have wanted to have more close contact with the facilities and the community units in order to have better outcome for the study. But with other competing activities, that was the main challenge. Yeah, the time factor.
Okay. Mm-hmm. So who was on the team actually
the team, yes, the team was led, the toolkit's technical advisor was Svetlana. Svetlana is based here in the head office, but I think now she's a consultant. Then in Kenya, there was Samuel Wakibi, Edward Kunyanga, and me, and also my other colleague, Dr. Amos. So there were about 4 of us, yeah.
And about how many health workers were there? Who did you work with?
From the facility, we had about 10 healthcare workers, and from the community unit, we had about 10. Yes, yes, directly working with. Yes.
I think that's all specific I have. Is there anything else you want to add or you think people should know about the toolkit?
Yes, I think the toolkit is, like I said, we are finishing the draft. I mean the toolkit, and it's a generic toolkit that can be adapted to whatever situation whatever country you can adapt it. It's a generic one, so that's a plus for the toolkit. Plus the toolkit has a data use component that's really strong, that gives you information on how to advise the district managers to use the data, which I thought was a very strong component of the toolkit. It has specific questions on what to ask of the referrals data, how to ask it, how to get the most out of the referrals monitoring data. So the data use component of the toolkit is really strong. Yes, and like I said, it's generic, so it can be adapted to different countries. Yeah, that's another strength of the toolkit. It's generic.
No, it sounds like a really good tool.
Yes, yes, I would encourage everyone to adapt it
Mm-hmm.
and start looking at their referral systems. HIS is Community Health Information Systems, and Community Health Information Systems is basically strengthening the data that's coming from the community, the lowest level, the level 1, the community, yeah. So the CHIS is a system where, yeah, data from the community gets up to the national level. Yeah, that's the CHIS. And in Kenya, we have a division of community strategy that it's the government of Kenya, but within the government of Kenya, the Ministry of Health, we have the division of community strategy, and the division of community strategy gives direction for community health information systems. So we have a community strategy that in Kenya that gives direction on what is a community strategy, what is a community unit, who should be in the community unit, how should the data, how should the community unit, community health workers behave around the community, what kind of messages should they give out to the community, how should they capture the data. So in Kenya, we are very lucky to have a government-owned system. So the government gives direction to all partners, be they USAID, CDC, on how the community strategy should be implemented.
So what is this work there? You said it's community to the government. So what do they do with it once they get the data out of the government?
Okay, good question. Right now, like I said, the community health information system is quite weak for now. We don't have data flowing from the community to the national level. And that's why we are there, to strengthen that system, to ensure that data is flowing from the community to the national level. And why is the system weak? The system is weak because of several reasons. The community health workers are not trained in collecting data collection for the national tools. The national level community strategy unit has developed tools through a technical working group, and people have decided these are the indicators that we need for Kenya, for the community. But when it comes down to the ground, the community healthcare workers are not well versed with the data collection tools. Then there's other challenges that data collection tools are not actually available at the community. So there's issues of training the community healthcare workers on the tools and making sure that they understand what they are doing, they understand the data elements in a very simplified manner in order to have the data flow from the community unit to the national level. Yes.
So you do trainings to help with that. Are there other things you do?
Yes, as Measure Evaluation Kenya, through the Associate Award, even now, through the measure, we're currently in Measure Evaluation Year 4 and going into Year 5. What we are doing with strengthening of the CHIS, the Community Health Information System, is that we have been assigned by the government of Kenya some specific community units to work with. And these specific community units that we have been assigned to by the government, we are supposed to ensure that they are well versed with M&E at the community level. First, they should have data collection tools. Secondly, they should be able to interpret the data elements in those tools. Third, they should be able to use data at their own level even before it's transmitted to the upper level. So that's basically what we are doing now. And the interesting thing about what we are doing now is that we are going to create centers of excellence per county. Kenya is moving into the devolution system. Right now we have regions in Kenya. We have 8 regions in Kenya, but we are moving to counties. So we'll have a total of 47 counties. We're calling them 47 governments because they'll have their own directors of health and really standalone counties. So as Measure Evaluation, we're going to have one community unit per county that's going to serve as a center of excellence. We want to make sure that that community unit is an example for the other community units around the county. And how we want to do that, our strategy for doing that is ensuring that we employ innovative technologies for collecting of data. First of all, make sure that the community healthcare workers totally understand their data elements, are comfortable with working with paper-based data collection tools. Then from there, use mobile technology, for example, as an innovative example of transmission of data. Data use ensure that their monthly, if they're going to have monthly meetings, those monthly meetings are used in a constructive way to discuss data at their level, so that the other community units around there can learn from the COEs and measure evaluation is going to set up. A community unit is, right now the strategy says that a community unit should have 50 community members. So how a community health care worker, there are 50 community health care workers in a community unit. How the community health care workers are chosen, they're chosen through a baraza. A baraza is a public meeting in the community. And the community has the mandate of saying, yes, I know Kate, she's in my community, and I trust her to do the work of a community healthcare worker. Keeping in mind that the work of a community healthcare worker is pretty sensitive. I mean, this is a person who comes to your home, probably comes to your bedroom to look at how you're living, looks at the latrine in your, I mean, if you have a sick child, this is the person who you would talk to. If you have a sensitive, anything that's very sensitive, and we know health matters can be pretty sensitive, you have confidence that this is the person who, as a community, can represent health matters in that community. So the 50 community health workers are chosen publicly in a baraza. Then those are the community healthcare workers, and there's a governing body for the community health workers, and these are normally 10 people from the community. And these 10 people from the community should be, I would say, influential people, like retired teachers, a chief, someone who's influential in the community and who can govern the community health workers. So there's the community health workers who are 50, about 10 community health committee members. Those 10 should be influential people in the community, retired government officials. I mean, whoever the community feels is an authority in the community is part of that community health committee. Then the community unit should be linked to a facility. In Kenya, how community health care workers or a community unit reports its data is through the link facility. So if there's a referral to be done within the community should refer to that specific facility. If there's data to be collected, they should collect the data through the facility they've been assigned. So that is basically the composition of our community unit. 50 community healthcare workers, the community health committee, and a link person between the link facility and the community unit. This person is called a community health extension worker. This is the person who provides a link between the facility and the community unit. If there's any training to be done, this is the person to train the community unit. If there's any relationship that needs to be mended between the community unit and the facility, this is the link person who's supposed to do that. One thing to note about the community healthcare workers in Kenya, the community strategy clearly states that it's a volunteer. I mean, what they do is voluntary. They're not paid. They're not paid to do their community strategy work. The community healthcare workers are not paid, so what they do is voluntary. So we expect them during trainings, for example, if I were a community healthcare worker, obviously I have something else that gives me my daily bread, but in a week, I would be expected to visit my households, maybe 2 hours a week. Visit my households, see how they are doing, then go back to what gives me my daily bread. So community strategy for Kenya is voluntary. The community healthcare workers, they're not paid.
So how do they manage the volunteer work with their regular job, or are they all able to? That has been a challenge in Kenya, especially with the community units that we work in. One of the complaints that they have, or the challenges that they have, is lack of motivation. They're not motivated. I mean, some regions in Kenya, a household could be many meters away from, 2 households could be very far apart. And this community healthcare worker has to walk from one household to the other household, putting in mind that she has no bus fare, she's not being paid to do that. She's doing that because she's interested in community unit work, but still, I think the lack of a stipend or anything to motivate them has been an issue with the strategy in Kenya. They're doing it well, but it's the motivation. I think if they had something to motivate them, they would even do better than they are doing right now. Yeah. And how us as Measure Evaluation want to motivate the community healthcare workers, it doesn't have to be monetary, but something small like giving them a training them on data use or how to collect data, and then giving them a certificate at the end of it. That's a big motivation for them because they have a certificate and they can actually get something to do with that certificate. Meeting with them monthly and talking to them and hearing them what they are doing is also a very big motivation factor because they feel that, yes, what I'm doing is actually getting some attention and it's making a difference in my community, because we can't ignore that what they do is a lot. These are the people who refer people in the community to the facility. They refer women they influence women not to give birth at home and refer them to the facility. They know who is not taking their drugs for ART within the community, and they go to their households and talk to them and tell them you need to be taking your drugs because this is someone the community unit or the households listen to. So they do so much. So as Measure Evaluation, we look for strategies to motivate them so that even as we are coming up with our centers of excellence, we want to ensure that there's a sustainable way of motivating our community units that doesn't have to be monetary, so that it's sustainable. Because if it's monetary, what happens when Measure Evaluation funding ends? So those are the strategies that we want to ensure are in place with our centers of excellence.
Do you have any ideas for what kind of motivation you could give that's not monetary?
Yes, you could encourage them to start an income generating activity or table banking. What we are doing in some of our community units is that when they meet, we give them a small reimbursement of their transport. So out of that reimbursement, they could contribute, before they go home with the money, they contribute maybe 2% of that money and have, it's called table banking, and accumulate the money so they can loan each other in the group and kind of grow like that. Yeah, so there's table banking, there's coming up with ideas of income generating, keeping of beehives or growing crops or whatever it is. We want to get ideas from them for your community unit. What do you think would be a sustainable income generating activity? And how can we support you to do that? Yeah. So that when we leave, they have something to call their own and something that can generate some little income for themselves. Everybody wants to know what is coming, what is the work of the community healthcare worker? What are they doing? What kind of data are they collecting? So the data that they collect at the community is supposed to feed into the system and get accessed at the national level. So that's the link with the community health information system. They're supposed to collect data at their level and feed into the national system, so that we know these are the number of children who have been immunized in this. I mean, these are the number of people who have been referred from this community unit. This is what is happening in this community unit, and we can only know what is happening. We can only have evidence of what is happening if the data are being collected by the community unit. That's why we encourage them during our meetings. Look, we are moving to an age where evidence is key. You can't go to your designated household, have a chat and have no documentation for it. We need you to document it in the national data collection tool, so that when you say you have a lot of work, you have some evidence, you have data to show for it. So that's another way that we motivate them to collect the data. We first make them understand the importance of collecting the data. The data is evidence of their workload. Examples of the data, they have a household register. This household register, a register is a data collection tool, and they collect data from this register every 6 months. And this register is supposed to collect major events in the household. For example, a death, if it's a major event, or immunization. So this register is supposed to collect events that are happening with their designated households. Then they also have a data collection tool that they use monthly. So this monthly data collection tool is what is used to feed into the national system. So every month, the number of times they visit the household is supposed to be documented. Whatever they do in their household is supposed to be documented monthly in that specific register, and summarized and fed into the community health information system. Yeah, yeah.
So is there a way of verifying if the data is accurate, or?
That's a very good question. Yes, you could look at the data, but you could look at the data and trends, and look at trends over time for the household and see if there are data quality issues coming up from the trends. But for now, for community health information systems in Kenya, like I said, the system is just starting off. So we first want to get the data. You know, there's the issue of availability of data. Then once you get the data, look at the data, is the data quality. So now we are the first step, making sure that the data is available in the system. Yeah. And once we get the data coming into the system, then moving to data quality. In Kenya, like I said, Kenya for M&E is government-led. All the agencies, be they USAID-funded NGOs or CDC-funded NGOs, we are all working to support one national unified government system. None of the agencies is supposed to have a parallel system for M&E. All of us, we are supposed to support one system. So that one system is supposed to give all those agencies data. It's trying to strengthen the one system, and that's a government-led system. So once everyone puts their resources towards strengthening this one system, any agency that wants data can get data from that one system. Yeah. Okay. And that's why we are happy that in Kenya we have a government-led system. So we don't have parallel activities with agencies supporting different little systems. All of us are focused towards supporting the one system.
And so how long has the community health information system been going on in Kenya?
Oh, it's been there for less than a year, probably. Yes, yeah, yeah.
And are there any major results you think you've seen?
Right now, the districts and the national level are really advocating to have data getting into the system, because the reporting of data into the community health information system is really low, really, really low. So that's what the national level is working towards. All USAID partners and CDC partners who have an interest in community strategy are being made to ensure that data is flowing from the community level into the national system. I think people should know that the community health information system is, data at the community level is really what makes the community healthy or not healthy. So supporting the community health information system to ensure that data is, we can make decisions from that data is really important. And I'm happy that in Kenya, especially measure evaluation, we have a stake in that. We have centers of excellence that we're going to demonstrate the benefits of having an up and running community unit that is vast with data collection, with M&E. They are able to make decisions at that level and see what kind of changes to the community that can make.